Well, good afternoon or good morning, depending upon where you are. Welcome to today's webinar. This is the Best of the Symposium Beyond Aging Workers, brought to you by the Campbell Institute, which is the Center of Excellence for EHS at the National Safety Council. My name is Joy. I'll be doing the introductions here and also the Q&A afterwards. But let me introduce you to today's speaker. For the previous 17 years, Deborah R. Roy was president and owner of SafeTech Consultants Incorporated in Portland, Maine. She is certified by the Board of Certified Safety Professionals, the National Environmental Safety and Health Training Association, and by the American Board for Occupational Health Nurses. Deb Roy has managed the Health, Safety, and Environmental and Wellness team for LL Bean since 2007. The following video is an encore presentation of Deb's talk on holistic health and wellness at LL Bean, originally presented at the Campbell Institute Symposium in Scottsdale, Arizona in February of this year. Deb will be available after the video presentation for live Q&A with those on the webinar. In the meantime, while the video is playing, please feel free to type in your questions and we will get to as many as we can by the end of the presentation. And now, here's the video of Deb Roy.
Thank you. I may be a resilient Mainer, but it doesn't mean I don't like to get out of town when it's snowing. Thank you to the Campbell Institute, and also I want to thank Casey for the great setup this morning on total worker health, because as Doug mentioned, my responsibility this morning is to really bring this to a practical level and hopefully give you a little bit of research, but also give you some ideas on how you might be able to start this process of integration. So my goal today is really to talk about some of the research regarding health impacts of aging. And yes, there are some positives of aging as well in terms of the workforce, but my focus is really on what are our challenges. And then talk about the essential elements of a worksite conditioning program. That's one tool that you can use. And try to have you think about how you could use this or another tool to address the aging workforce. So first, the problem. We probably all have older workers that are aging in place. A lot of those workers are doing high-risk jobs. The problem is that those same workers have more limited flexibility and or strength. They may have more limited joint range of motion. And they may also have an increased abdominal girth. Okay? Some of you may be familiar with that. The goal then is to really take these workers and keep them working safely as they age. So a little bit about some of the health effects. And first of all, the color of the arrows is not necessarily positive or negative. So first of all, we have an increase in chronic disease. Basically, as was mentioned earlier, diabetes, hypertension, a whole variety of disorders that may exist, including obesity, in our workers that sort of come together and create more risk in the workplace. It also increases healthcare costs. So that's one of our major challenges is we have this workforce that's aging, and in many cases, the age of that workforce means that they're developing these chronic diseases, in addition to obesity. Older workers typically have a decrease in flexibility, in strength, and in lean body mass. Their muscle flexibility drops. Okay? And that means that oftentimes a job that requires somebody to bend forward, and that person may have done that job for many years with that same posture, they can't bend as easily as they could before. So you may have to think about that in terms of designing jobs. They may not be able to reach like they could before. And they probably can't twist as easily as younger workers. Now, bending and reaching and twisting, we all know from an ergonomic standpoint, it's probably not a good idea to begin with. But a 25-year-old may be able to get away with it, right? Or they think they can anyway. The problem is, as we age, that opportunity is no longer there. And those postures really then create risk. Muscle strength declines too. Here's the real happy message. It declines 10 or 20% between the ages of 20 and 50. And then it's a downward spiral. You have further declines of 25 to 30% between the ages of 50 and 70. Okay? So quite a bit of muscle strength decline over time. Lean body mass also begins to decline. It's about 2 to 3% every 10 years starting at age 30. Okay? So usually most people don't notice it very much in the first decade or so. But typically what happens is we start to gain weight, and eventually that weight catches up with us because now we are gaining fat and not muscle. And that continues to get worse. So the actual amount of muscle mass starts to decline around age 40 and accelerates after age 65. And that's why you will see people that are over 65 that will actually have limbs that actually start to shrink. And that muscle mass that they had at one time will actually start to atrophy. Okay? The key, what was that? So the key here is that as that body fat increases over the years, there's a greater tendency to gain that fat in the visceral area, so the abdominal cavity. And that's unfortunately what some men have figured out over time, is that their abdominal girth will increase. And whatever size slacks you wore before probably don't fit the same way now. And that's just a function of that shift of muscle. The key is that that increase of fat is really around the vital organs. So it's internal in many cases. That's actually the hazardous fat. And by depositing around the organs, it will put you at more risk for chronic disease. So that's the concern with that type of fat deposit. It's not just that it happens to be in the way. It really impacts both externally and internally. So NCCI, the National Council on Compensation Insurance, put out a report in December of 2011 about the aging workforce. And they said that the aging workforce will have an adverse effect on workers' losses and therefore the cost of workers' compensation. Okay? Now, you heard earlier some information about that idea. Well, the rest of the story is that the differences in frequency between age groups no longer exist. So in the past, we used to see frequency differences between older and younger workers. The latest data is not showing those frequency differences. What we are seeing is that older workers do have higher severity and higher costs of medical treatment. And if you look at indemnity versus medical costs for workers' comp, and you carve out the indemnity costs, because older workers may have higher wages, so as long as you're not hitting the cap in that state, you probably are seeing differences in the indemnity portion for older workers. If you carve that out and look at your indemnity cases, just the medical component, you will start to see a significant difference in workers above and below age 40. And I've actually stratified our data that way, and it's very clear. And it doesn't matter what injury it is, any of those indemnity cases, the medical is more. And the reason is because they typically are either restricted longer and or out of work longer. And anybody that's out of work longer or restricted longer, guess what? Has more medical treatment. And as was mentioned earlier, in those older workers, if you don't aggressively case manage, what will happen is that you will have aggressive treatment delayed, and you will have higher costs, because you really need to use some of the technology that's available earlier in a case of an older worker. There are typically comorbidities, and comorbidity is just a medical term for the other various conditions that people might have, whatever they bring to the table. And if they do have comorbidity, things like diabetes and so forth, and obesity, then that will have an adverse effect on that claim as well. So what are the solutions? First of all, as we talk about solutions, I do want to say from a positive standpoint that older workers do add value to organizations. They are the knowledge and the experience of organizations, and they are needed in our organizations. As was mentioned earlier, we just don't have younger workers to change them out with. And so the fact is, we need those workers and we need their capabilities, probably longer than we did in the past. And the fact is that despite this negative information about health effects, there are ways to counteract those effects to some degree. And those older workers do add value. So research has shown that regular aerobic activity and strength training can help older workers manage body weight and visceral fat. Okay? And the visceral fat is that fat around the organs that is the most serious. The right exercise can even slow the physiologic aging clock. Now, unfortunately, that doesn't all make us look like we're 30 again. But from the standpoint of the bodily functions, you actually can improve the condition. And aerobic exercise does help to maintain the heart and lungs, and it increases cardiovascular fitness and endurance. So those are things that we can improve. Lifting weights 2 to 3 times a week increases strength by building muscle mass, and it also increases bone density. And that, for both men and women, is important. It is a fallacy that only women have to worry about bone density. Keep in mind that bone density makes a difference as we age, because remember, we all have balance challenges as we get older. The body does not adapt as well to balance opportunities, such as ice at this time of the year. And one of the things to keep in mind is that you can actually, with exercise, improve your balance. You can improve your condition in terms of bone density with weight-bearing exercise. So a little bit on the benefits of exercise, and this does come from CDC. There was a 12-month study that was done at Tufts University in the Boston area, and they demonstrated that just 2 days a week of progressive strength training significantly increased the capability of those individuals. And in fact, they saw 1% gains in hip and spine bone density, and bone density improvements are hard to come by. A 75% increase in strength, which is pretty amazing, and 13% increase in dynamic balance. The control group actually had losses in all. So it really did show that the improvement did affect the situation. And falls for people as they get older is one of the major hazards. And for those of us that are dealing with snow and ice this winter, you're probably finding that your parking lots and parking decks are becoming quite a challenge from an injury standpoint. And part of that is if you have a workforce that is aging, they may not have as much capability to balance in those adverse conditions. And in those cases, you will need to come up with some other technology solutions or simple solutions such as footwear to address those. So I'm going to tell you a little bit about this case study, and this was a project that we did at L.L. Bean. First of all, L.L. Bean, for those of you that don't know, is an outdoor company. We're based in Maine. We have retail stores both in the U.S. and in Japan. Our operations in the U.S. include distribution, call centers, and some manufacturing. In Japan, we have both retail stores and call centers and office. The company was actually founded in 1912, so we're over 100 years old. And our average age of those employees in our main operations is age 50. And lest you believe that our retail employees outside of Maine are younger, they are not appreciably younger. They're about age 45. So we don't have a workforce of 20-somethings that we're working with. Maine is considered one of the oldest states in the nation. And we actually have a median age of 43.5%. And this was the 2012 data, the latest data available. One of the challenges that we have is we're really a baby boomer state. What that means is we have an older population and we don't have younger workers coming up behind. So unlike some states who have that boomer population and still have younger workers coming in, we don't have that. And that's why the age is going up so rapidly. Our average longevity in the company is 12 years, and many employees are in the 20-plus range. So the good news about longevity is you keep that intellectual capital. The bad news is that from a healthcare cost standpoint, from an injury standpoint, you also have an aging population that you need to work with. And it has, over time, allowed the company or benefited the company to try to address that workforce. So I'm going to talk a little bit about what's on this slide and then give you a little bit more of an overview of our approach. So this slide is actually part of our philosophy statement. You'd call it a health and safety policy for our organization. And you'll notice at the top, if you can see the print, it says safe and healthy living. Safe and healthy living is one of our 6 core values of the organization. Again, company's been around for over 100 years. It's based on very traditional core values, things like honesty, integrity, outdoor heritage, and so forth. And one of those is respect for people. One of them is also safe and healthy living. So I have the benefit of having that as a core value of the organization. And the leadership truly believe these core values and function within the parameters of these core values. Because of that safe and healthy living core value, we have a lot of components that are in place that may or may not be in all organizations. And they've been in place for many years. So, for example, the wellness programming has been in place since the early 80s. Pretty much at the beginning of when some of these wellness programming started in the U.S. So that's been in place the entire time. There's been safety management systems going on for some time. So we have that base component, the safety element, we have the wellness programming. We have on-site occupational health clinics, which I was interested to hear Casey talk about the evolution of, because we're in the same place. We're actually evolving our traditional occupational health clinic back to a closer to primary care as part of the Affordable Care Act, and that is where the industry is going. So those programs are all available to our employees already. The key with the approach is to integrate all of the elements. So my responsibility, as you may have heard from the intro, is I have the global EHS component, but I also have the wellness component. And all of those are part of one department. Now, I don't have the healthcare spend. I do have the workers' comp. The healthcare component is in our benefits department, which is in HR, which is a separate department. But both departments, along with facilities, all report up to the same senior leader. And I report to the executive committee. So the advantage with that is, number one, I have a voice for that larger component, but we work very well with our benefits group and actually have regular meetings with them and have integration meetings, so called integration meetings, so that the communication actually happens. And we're a very meeting-driven company. So that actually works in our organization. That doesn't mean we always agree, but it does work. And what it's allowed us to do is to craft solutions and strategies that actually are integrated. So when our benefits group decided that based on cost, we needed to move to high deductible health plans, we made sure that those high deductible health plans had components that actually supported our employees. Those are things like prevention services were still paid at 100%. Some of the things that are in ACA now were already in our program all along, long before they had to be. And employees were used to using it. Because of the prevention focus, we have a much higher percentage of employees that use their primary care physician and go for their regular physical. There's really good data that shows that if people have primary care exposure, then they generally have chronic conditions addressed sooner than later, and they don't end up in the hospital with a chronic condition. So that's one of the benefits of having that preventive component. We also have a whole variety of other programming that supports, in addition to all of the traditional safety elements and the safety management systems and the engagement strategies from a safety standpoint, we have other targeted programs. So our health risk appraisal program, for example, includes blood work. We get that data on an aggregate basis and target the risks of the organization. So we can look at a building and say, what are the most common risks in that building? And then from that, make a determination about what risk-based activities need to happen in that building. So to give you an example, all of our programs have something bean related. So this one's called Bean Strong. And Bean Strong started in one of our 3 call centers that are in Maine. We also have the equivalent number of employees that are home agents as well. But one of our call centers, which is in the northern part of the state, happens to be in a community that has a very high obesity rate. And guess what? The obesity rate in that call center, meaning that you have a BMI of 30 or greater, is 63%, where it was. 63%. And average in the U.S. is almost half that. So that, and that average was, for the company, average was similar to the U.S. So we had this outlier facility. Now, as Casey mentioned, there are some jobs where you do have people that are more obese than others. And we thought that that was going to be the issue. Interestingly enough, we have home agents and we have 2 other call centers that don't have the same degree of obesity. So I would say that it was more geographic based than anything else. And we already had adjustable workstations, we had standing stations, we had all kinds of other opportunities from a safety perspective and ergonomic perspective in that facility. We still had a high obesity rate. So we needed to do something different. And what we did is we actually took volunteers, did presentations to the entire call center, told them what the numbers were and why we were concerned, and offered a program, a year long, that included a well-being, so the mental health component, a nutrition component, and an exercise component on company time, 3 days a week for a year. And we have pre and post data, and we followed those individuals. We've done a similar kind of thing in the second call center. The third call center right now, we're actually doing what's called the Diabetes Prevention Program, which is a CDC program that I would also recommend. The Diabetes Prevention Program is a 16-week program, and you can Google Diabetes Prevention Program, and you can bring up information. It is free. And that's a public-private partnership that's available as well. So if prediabetes is a concern in your population, that's an opportunity. But those are examples of the other kind of programs that are available from a total worker health standpoint. And if you have a diabetes issue in your workforce, or you have an obesity issue, they're often tied together. And these are the kinds of strategies that we've put in place to address the targeted risks, as well as the other types of risks that we are concerned about. And that means looking at targeted as well as non-targeted. Non-targeted, an example would be having fitness centers available, or subsidizing gym memberships, or having classes for physical activity. All of those things would be non-targeted. So the concept for this particular program was really conditioning. And it came about in response to a concern that employees were aging in place and still performing highly physical jobs 10 or 20 years after they had their post-offer exams. Okay? So these are people still doing heavy work, and they were fit at one time, but now they're getting older. And all these things that I mentioned earlier are starting to happen, and they're still doing the same jobs. So what do we do about that? You know, how do you address those employees, and how do you keep them fit doing that job? Interestingly enough, part of the story with this is the vice president of our distribution operation had said to me, well, can't we just do post-offer exams on all these people? And I said, okay, we can do that. Legally, the way that would happen is if you have 100 people, we would do post-offer exams on all of them based on the criteria for that job. And we do dynamic strength testing because this job is level 5 in our operation, which is the highest level. And they would go through that testing like they did many years ago. And I said, here's my bet. 80 out of 100 aren't going to pass. Where are you going to place them in your organization? Because it is your responsibility to address those individuals and find appropriate work. And after his mouth dropped open, I said, how about another approach? And let's look at how can we support these individuals as opposed to saying, how can I get rid of the people that are not fit enough to do this job? So an overview of what we call Jumpstart. We call this program Jumpstart to Fitness. It's a 12-week supervised exercise program on company time. It included pre- and post-testing along with follow-up after the program. And the leadership actually chose this particular case handling group because of the high risks for shoulder and shoulder injury and because of just the number of injuries in this group. By the way, we had done 5 pilots of this program program in other facilities before and tested various methods of doing it. One of the things we found by accident is we looked at productivity in one of those pilot groups that happened to have a unit per hour measure. And we found that despite the fact that they were getting paid time to do this program, their productivity went up on a shift basis. So allowing people to actually get more fit allows them to be supported to be able to do the work throughout the day. So this is the job. It's 100 people. They're case handlers, so they're material handlers, traditional material handlers. It's the most physical job in the warehouse. They have to lift up to 50-pound boxes, and the lifting may include lifting to 78 inches. Okay? Overhead, which, as you all know from an ergonomic standpoint, is not recommended. It is an occasional in this case. We have eliminated most of those lifts through software changes and loading onto lower shelves, but they still do exist at times. The trucks themselves are unloaded to a conveyor, and they're palletized. Boxes may also be physically moved from pallet to the conveyor or to a U-boat, which is what you see here. In addition, these are PIT operators, so they're going to operate various types of PITs, and in this case, this is an order picker, where they're going to go up through high bay in a rack and pick boxes off the shelf and load them onto the truck that they're on. They may also depalletize onto another rack. So a lot of different movement in different places. The methodology for this program was the wellness staff presented the program to the entire case handling group. Again, this is voluntary. Employees who are interested in participating were asked to complete an application, short, couple pages, but we wanted to see what their motivation was. We wanted to make sure they were ready to participate. About half the department applied. And we had a couple of people that actually, when we started looking at who we were going to choose for the program, actually weren't even physically able to do this program yet. They had other medical issues that we needed to address, and we actually took them aside, had them work with our physical therapists, and got them up to the level that they could even do this program. And they actually waited till the next cycle, and we included them in the next program. So this is an example of some of the pre and post testing. So we did both a physical therapist doing pre-testing and a fitness individual. So this is the basic testing. You'll see on the left-hand side, this is a 3-minute step test, standardized step test, and looking at doing vital signs. In addition, they did flexibility, strength testing, and so forth. The intervention itself was really focused on conditioning employees by creating muscle balance, strength, and flexibility without re-injuring the same body parts. Remember I told you earlier that a lot of these people had shoulder issues? We had a lot of rotator cuff injuries, so some of these people had had surgeries. And in most cases, the injuries that occurred not because they weren't strong enough. These were people that had always done physical work throughout their lifetime. They hadn't lost as much muscle mass as the rest of us who might be sedentary. What happened is they had imbalances in muscles. So they had strong muscles in one area and weaker muscles in other. And what happened is that then created shear forces that created injury. And that's one of the other challenges as people get older. If you have people that are doing heavy work for long periods of time, they generally get conditioned to a certain range of motion. The problem is when you work outside that range of motion, remember I told you earlier, flexion, extension, twisting, and so forth becomes more difficult with older workers. Well, what happens is I can get away with that twist when I'm 25. I can't when I'm 50. And that's what's happening in this case, is they were not individuals who were deconditioned. They were strong. They just didn't have the muscle balance. So this was a very targeted program to look at balancing those muscle groups to prevent injury and to strengthen those areas that were frequently getting injured in these jobs. The program was held on site in the warehouse fitness room, and I should tell you that all of our major facilities have fitness rooms available to the employees and spouses. They're free. They are partially staffed by my staff because I don't have enough people to be there all the time, but everybody does get evaluations initially every 3 years, initially and then every 3 years by the fitness staff if they choose to use the room. These programs are held during normal work hours and both first and second shift, because one of the things we wanted to do was be sure that we offered the program to the entire group and not just to the day shift. It included 45 minutes of supervised exercise 3 days a week for 12 weeks. The class consisted of things like foam rolling, stretching, core work, resistance band work, use of a medicine ball or an exercise ball, and hand weights. So this was not heaving weight kind of exercise. The staff for this was qualified fitness instructors, so this was my in-house staff or contract providers who provide classes who are qualified fitness instructors. The physical therapy staff also assisted in the design of the program, the pre- and post-testing, and at the beginning of the program they did attend some of the classes, particularly to keep an eye on some of the people that might have difficulty with the initial instruction and make sure that their range of motion was appropriate. The funding for the program was that people used 15-minute break time for part of it. Okay, so one of their 15-minute breaks a day, and the company provided the additional 30 minutes each of the 3 days, so a total of 90 minutes a week. The funding for the wellness and the physical therapy staff was provided as part of our existing budget. I'll show you that cost in a moment. And the distribution operations actually funded the wages for the program. The results. First of all, the average age in this group, if you can imagine, is 46 years old. So this is the population that's lifting 50-pound boxes. And it was quite a wide range. The average years of service in the group were 11 years, so very similar to the average in the company of 12 years. Not a whole lot of difference there. The outcome was fantastic. So if we look at the wellness strength testing, the first on the left-hand side is the muscular strength. This is doing push-ups. They had a 44% improvement in this group. Muscular strength doing a full sit-up was a 32% improvement. And you can see that all of the measures did improve: muscular endurance, cardio endurance, and flexibility. Flexibility is a much more difficult nugget to try to get at, but we did see improvement with that as well. The physical therapy assessment was really interesting. If you look at the far right, you can see that the lower trap strength, which is back in here, improved 89%. And if you're dealing with shoulder injuries, that's huge, because that's the area that you're really concerned about reinforcing, because that's the way you prevent shoulder injuries. You've got more strength in that upper back as long as you have balanced that. Also, external rotation strength was improved by 57%, and pec flexibility here was improved by 54%. Pec flexibility is a big issue, particularly in males, and as they age, because this is the hunch. Okay? So being able to have flexibility here and strong upper back really keeps the posture in place, and that normal posture is what protects the low back as well, and the joints. We also did a survey with this group, and I thought it was really interesting. They said they had more energy, they're more flexible, they're stronger. Even stress improved by this exercise program. About 50% said that. They said they increased their daily steps. And an interesting finding, 42% said they lost weight. We weren't looking for weight loss. We just happened to include it as part of pre and post testing, and we weren't even looking for it, and we found it anyway. As you can imagine, people were quite satisfied with the program. We had near 100% satisfaction on all of our surveys, and they really felt it was helpful to support them in this way. Now, keep in mind, this is a very engaged workforce. We do culture surveys every year. Health and safety is part of it, but overall culture is already pretty high. And we still are getting excellent satisfaction in the program. This testimonial, I think, says a lot. And so the idea here is to create resilience in these individuals. This isn't the only thing you can do. And I will tell you that in this same warehouse, we have robotics. We have lift assist devices. We haven't looked at just the individuals or the behaviors. We have actually put all the engineering controls in place to try to address this work. The fact is that there are many workplaces where you can't get away completely from manual work. And so you really need to manage that work and help condition those individuals doing the work as they age. A little bit on the cost. I told you earlier the wage was paid for by the actual area, and the instructor cost came from my budget. The total program cost was only a little over $18,000. Okay? And by the way, this wage that I have on this slide is not a loaded, benefit-loaded wage. Our benefit load's about 53%, so it's a pretty big hit on this. We were just doing a simple analysis of what's our cost. If you then look at the savings, this may be something different that you may not have used before if you haven't dealt with the wellness or health side. You can look at potential healthcare cost avoidance. So in this case, we actually, based on the pre and post data, had somebody that went from obese to not obese. We had people with high blood pressure, 4 of them went from high blood pressure to low blood pressure, or normal. And we had 6 who had physical inactivity. Now that seems kind of an oxymoron for people who are material handlers, but these are people that were doing nothing other than being a couch potato outside of their regular job. Okay? 6 of them went to continuing activity afterwards. If you add up that excess cost avoided, it's over $10,000 for one small group. And this data, by the way, is accessible from HERO, which is the Health Enhancement Research Organization, and it comes from a study called 10 Modifiable Health Risk Factors are linked to more than 1/5 of employer-employee health care spending. So there are research studies that are available to actually support this kind of data. So from that data, how about if we do a simple ROI? So we take that cost savings and we take the cost and we just divide it out. For this particular intervention, this small intervention, we have an ROI of 55 cents per every dollar spent. Okay. So from an engineering perspective, that wouldn't be enough. Okay? But this is just the health piece. What if we looked at it from a workers' comp standpoint? So in this same group, in 2012, which was before the intervention, we had 10 work-related injuries, workers' comp injuries. 3 of those were indemnity cases, and 7 of them were medical onlys. 5 of those 7 medical onlys were treated in our occupational health facility on site. So I have no cost associated with them in this data that I'll show you in a moment. The right way to do this is to actually evaluate that cost for our on-site care and add it in. It would be an even greater number with that. In 2013, which was the year of this intervention, we actually had 2 injuries. And guess what? In 2014, we had 0. And in 2015, for the last couple of months, we still have 0 in this same group. And here's the actual data. So again, not looking at the medical costs for those cases that we treated in-house, the 2012 cost is $59,835 versus the 2013 cost for those 2 cases of $1,181. As you can see, the severity was much different overall just from those costs. The 2012 cases included some surgeries, and they were rotator cuff surgeries. And so if you take that data and look at the ROI, again, just a simple ROI, you get a 3-to-1. Okay? And that's without loading all the additional data. Most of our wellness programming that we've done doing a complex ROI analysis, we're seeing an 8-to-1 return. And if I look at a 3-year average on those programs, I'm seeing at least a 4-to-1 on our overall programs. So from a financial standpoint, there is value. There's also value, and this is what our organization focuses on, there's value in reducing injuries. And that's really the long-term benefit. Because if I have several years of no injuries or very minor first aid related injuries with this group that are treated very quickly, then that is a huge cost savings long term. So some lessons learned in this program. The ideal class size is about 10 to 12 people, so this can be pretty labor intensive. You have to run multiple classes in order to run that many people through. And part of that limitation is really the program group itself and how they work together, but also the size of your facility. Work conditioning is important even for physically active jobs, and I don't think most people realize that they still have to do some kind of regular activity and not just work at work. Because the perception is if you work hard at work, you don't have to do exercise. And that's not true, particularly as we age. Leadership support was critical. They really supported this whole intervention. They paid the wages to do this program, and they really supported it. And quite frankly, I don't need to do any of these ROIs on any of these programs because I have that safe and healthy living core value, and the entire leadership team supports that. We do it because I want to show that from a business standpoint, we can actually add value. You want to develop a structure from the beginning that includes program expectation and guidelines. One of the things we learned is that you need to deal with attendance. You need to give people expectations. This is an opportunity for them. It's a volunteer effort. But if they're going to sign up and not participate, they're taking a space away from other people who weren't able to get into the program. And generally, that's all we had to say, and everybody understood that. And then finally, make sure that you do medical clearance. If you don't have some routine process in your own organization, have people go to their primary care provider and get documentation that they're cleared to do this, particularly if they have had injuries recently. And then just keep it simple. We found that keeping the whole process simple worked best. So this is an ongoing project. We have 9 more 12-week classes that are going on now in 3 different buildings. Again, we're still doing follow-up surveys at 3 months after the program and follow-up testing at 6 months. So our ongoing data really looks very similar to what you saw. And we're trying to continuously improve these sessions based on the data. So it's an evolution. And I would recommend that you continue to do that with any intervention you use, that you evolve it depending on the group. One of the key learnings we had was that when we tried the pilots earlier, if we did it in areas where you had just one department doing the activity, they tended to continue it after the fact. If you sort of opened it up to a whole building and had scattered people from a building, they didn't support each other as well as they did within a department. And so in a department, they continue the exercise and they sort of shame each other into continuing after the program on their own. Okay? Some final thoughts. Think about how you could apply this idea or some other intervention in your population to really integrate the wellness and the safety component. Keep in mind that studies of 90-year-olds have even shown strength gains of close to 200%. So it's not a situation where you can't do anything just because you have an older workforce. And I think that's the positive note today, is to really think about this is a positive reinforcement of age going forward. Older adults who do perform regular strength training are 30 to 50% stronger than those who remain sedentary. So it is worthwhile focusing on that strength component. Thank you.
Okay, so I hope that you enjoyed that presentation from Deb Roy about Beyond Aging Workers. Deb is available right now for a live Q&A. Just as a reminder, you can type in your questions into the box on your screen, and we will get to them. Deb, are you there?
I'm here.
All right. Well, we have some questions here that have popped up, and we will take them in order. First question is, what is the biggest challenge in gaining employee buy-in for wellness programs, and what is a good strategy that you have found for obtaining this?
Okay. I would have to say in our population, because of our culture and the level of employee engagement we have, that it's a lot easier than in a lot of companies. So I would say it's less of a challenge for us. But there are still things that I think do make a difference. For example, the time piece. People overall feel that they don't have time for exercise, particularly if they're having to travel to and from work a long distance, or they have other responsibilities at home. And so having the class, if you do something like this, integrated into the workday and paying for that time does help to support it and gain employee buy-in. Keep in mind that they used part of their break in this example as well as additional paid company time, and it was for a discrete period of time, so for 12 weeks. And I think that makes a difference too. Some of my wellness staff initially, when we first started doing the pilots, were concerned about the idea of paying people for exercise, that just wasn't the right approach. And what we found was this is a kickstart or a jumpstart, which is how what we call the program is Jumpstart to Fitness. It really is a start as opposed to a long-term situation. Secondly, I would say you have to build trust to get buy-in. And again, in our case, that wasn't difficult, but we use our aggregate data from our health risk appraisal program, and we present it to the leaders in a building first and then to the employees. So we're very open and transparent about the data. And again, this is aggregate data. This is not individual data. It is aggregate data for certain variables in our program. And then third, I would say support is part of your strategy. It needs to be a supervised activity with some credentialed individuals that do know what they're doing, and you need to be able to show concern for those individuals. Our leadership is fabulous at that, and our frontline leadership really tries to support the individuals. I think this whole program really shows the support for those employees. And then lastly, I would say that it needs to be voluntary. none of these programs that we offer are mandatory. And so it really needs to be presented as a voluntary opportunity for employees and supported in that way. And I think that makes a big difference to improve the buy-in.
Okay, great. Thank you. Here's another question. How did you handle requirements to compensate those not participating in the program?
That's interesting because we did actually get some people initially that fussed about that. That they said, well, I'm working out on my own and why aren't you paying me? But quite honestly, what we found was that the coworkers of these individuals started to really see the changes in these individuals, and they then really supported them. And other than right at the beginning, that went away completely because they are long service employees for the most part, and they saw the improvement in this group, and the whole issue went away.
Okay, great. Thank you. Another question here. If an employee is injured during a company-sponsored wellness event, is it considered a job-related injury?
Yep. Here's where your state workers' comp law comes in, as well as OSHA recordability. So from a federal standpoint, as far as OSHA recordability, this type of program typically would not be considered to be mandatory, and therefore it would not be OSHA recordable. On the other hand, from a workers' comp standpoint, depending on the state you're in most cases it would be compensable under workers' comp, and here in Maine it was. But I will tell you that of the 2 cases we had in 2013, one of the individuals was in the class, and the class probably had some impact on that individual. But keep in mind that we were talking a few $100s for that case versus several thousands for surgery. So I would say that the cases that we did have were very minor, and they were at the first aid level for the most part.
Great, thanks. Question here. Could you give some of specific exercises or examples of from the strength conditioning course?
Sure. And I do have a sample document that Campbell Institute might be able to provide to you. I believe they do have it posted that has specific examples in it and the timing and so forth. It's quite detailed. But for example, in this case, you'll notice some of the pictures that were in the slide set show bands, and people were either against a wall or on the floor. So what they were doing in that case was strengthening with bands. They did do a cardio workout at the beginning. We did do this in a fitness room, so we had the equipment available. But you could actually do this in a conference room. People can march in place to warm up or do other kinds of activities to warm up, and then use bands or hand weights and so forth. So I would say that in this case you can use the body and you can use some minor equipment to actually do those activities. So hand weights, bands, the big balls that you can roll on and do various activities on the balls. You can also use medicine balls, small medicine balls, to create weight shifts and work with people with individual feet to improve balance.
Okay, great. Another question here. Some regulatory agencies such as the EEOC have close scrutiny and oversight with wellness programs. How do you manage that?
The key here is to keep this voluntary. And we haven't had a problem with that issue. So everybody in our workplace pretty much would be considered an older worker by definition. So these programs are offered to everyone. So there's no discrimination in that situation from an EEOC standpoint. Under the Affordable Care Act, the new regulations do allow for wellness programming, and that really applies more to the testing components of the program, so meaning health risk appraisals and so forth. As far as these activity programs, that there is no restriction under the Affordable Care Act.
Okay. And maybe one other question that you can answer quickly. When implementing the wellness program, did you see a spike in recordable injuries?
We didn't. As I mentioned, we only had 2 injuries in this population in 2013, which was the year of the intervention. Since then, we have had, I mentioned at the beginning of 2015, we had 0 injuries. We still have 0 injuries out of this group, and we have introduced more technology into the warehouse where this employee group works, but obviously they're also a couple years older, and we're not seeing any increase in injuries.
Okay. Well, thank you, Deb, for being available for the live Q&A. On behalf of the National Safety Council and the Campbell Institute, we thank you very much. And we are at the top of the hour, everyone. We want to thank you for joining us for the webinar. This was the Best of the Symposium Beyond Aging Workers with Deb Roy. We appreciate your attention and participation in today's event. A recording of this webinar will be available at the Campbell Institute website. That's www.thecampbellinstitute.org. And to hear more informative and engaging presentations on EHS topics like the one you just heard, plan on attending the Campbell Institute Symposium taking place February 25th and 26th in Austin, Texas. You can register online at thecampbellinstitute.org/symposium. And also, to assist the Campbell Institute in its future webinars, please fill out the short survey currently on your screen. Thanks again for attending the webinar, and have a great day.